The new dimension of jet ventilation. SHFJV. Superimposed high-frequency jet ventilation. High-frequency jet ventilation has become an established procedure in both surgery and intensive care medicine. Conventional ventilation techniques pose a number of problems for the surgeon, as well as for the anesthesiologist. For example, microlaryngeal surgery, in which both the surgeon and the anesthesiologist share the same approach. The anesthesiologist needs a secure and uninterrupted airway, while the surgeon needs access to the surgical field and good visibility, as well as time and freedom to manipulate organs, structures and equipment, such as surgical lasers. High-frequency jet ventilation involves the application of a volume of compressed gas under high pressure and at high speed through a cannula with a ventilation frequency of 2.5 to 25 Hz. A single portion of gas has a tidal volume of 1 to 3 milliliters per kilogram of body weight. There can, however, be complications when the jet cannula becomes dislocated or is poorly positioned. Further, when only one jet flow is used, gas exchange cannot be well controlled, meaning that hypoxia or hypercapnia may develop. The ideal form of jet ventilation is superimposed high-frequency jet ventilation. There is only one jet respirator that allows normal frequency jet ventilation in a frequency range of 1 to 100 impulses per minute, with high-frequency jet ventilation in a frequency range of 50 to 1500 impulses per minute. The gas is supplied with surgical instruments specially developed for this system, with different jet applicators and jet catheters. The following approaches may be used for gas supply. Tubeless transbronchial approach through a rigid bronchoscope or tracheoscope. Infraglottal transtracheal puncture with a Ravussin cricothyroidotomy needle. Infraglottal ventilation via jet catheter. Supraglottal ventilation with the jet laryngoscope. If one considers application with the polygonal jet laryngoscope, the advantages of SHFJV with tubeless supply are obvious. The jet laryngoscope provides simultaneous low and high frequency ventilation via two jet nozzles integrated into the endoscope in an open system. Both ventilation nozzles are so positioned in the outer third of the tube that the primary jet pressure changes to a low ventilation pressure in the tube and not in the surgical field, so preventing pressure damage to the mucosa. At the same time, the Venturi effect is shirted to the outer third of the laryngoscope. As an additional feature, this laryngoscope also has separate pipes for continuous monitoring of the ventilation parameters as set. The top pipe at the distal end of the laryngoscope is for gas analysis, like FiO2, and patient's expired end tidal CO2. The lower pipe is for the measurement of the airway pressure. The opening on the instrument grip is for moisturizing and warming the ventilation gases with a special active moisturizing system. The low-frequency jet ventilation produces a variable inspiratory plateau, but no expiratory pressure plateau. High-frequency jet ventilation, in contrast, produces, depending on frequency, length of inspiration and the dimensions of the jet tube, an intrinsic PEEP, and so an end expiratory pressure plateau. Combined high and low frequency jet ventilation allows a continuous positive end expiratory pressure plateau and an additional elevation of the inspiratory pressure plateau. Measurements with a lung simulator very clearly show that only the combination of low and high frequency ventilation provides sufficient respiratory displacement, especially with limited pulmonary compliance. First, one sees the achievable respiratory displacement with low-frequency jet ventilation alone, and then the respiratory displacement with high-frequency jet ventilation at 1 bar and 8 Hz. Finally, one sees very impressively with unchanged respirator settings that the respiratory displacement almost doubles when low-frequency ventilation and high-frequency ventilation are used together. This multiplication of the displacement is due to the optimal utilization of the Venturi effect. Both low and high-frequency jet ventilation used alone are inferior to the combined application, superimposed jet ventilation.